शेड्यूल, मैं नाम भूल गया उस टाइम, शेड्यूल उसके अंदर होती है ना अपने बैलेंस शीट के अंदर, ऑडिटेड बैलेंस शीट के अंदर शेड्यूल 1, शेड्यूल 2, शेड्यूल ए, शेड्यूल बी, शेड्यूल बी, that schedules also, everything will come.
Start. Sir.
So, greetings from Indian Medical Association. We present to you our webcast from both IMA hosted by IMATV Access. I have with me my national president, Dr. Marthanda Pillai, with him is incoming president, Dr. S.S. Agarwal, and our immediate past president, Dr. Jitubai Patel. So, welcome to our show. First of all, before we start, I will request our national president to give his address.
Dear friends in IMA, our this year term is the pageant, and we have a lot of issues which we are trying to sort out. To some extent, we have succeeded. At least we could force the government to appoint an interministerial committee to examine the major 5 issues that is bothering Indian Medical Association, the public health at large, and the doctors in their practice. The issues, as you know, are the assault on doctors, which are now becoming almost a everyday affair. We always say that in every minute an accident is taking place on the road. Now we have to say that every day one doctor is being assaulted in India. And definitely in a civilized society, taking law into their own hands, particularly in the name of the patient by antisocial elements, is something which any conscientious, law-abiding citizen should strongly protest. IMA has been harping on this, and government has now, we feel, has realized that a solution to this has to be found, and we are going to have more deliberations with the government on this issue. Hopefully, a central act will come into force whereby such things should be declared as a criminal act, an unbailable act, and appropriate amendments should be made in the Police Act, so that whenever there is a report of such things, police can act and arrest the culprit, so that this tendency can be curbed.
Dr. Agarwal, let's concentrate on the violence. Let's concentrate on the violence. We have a act in 17 states.
Yes.
Central act is not there. Even in those 17 states, it is not being properly implemented. Okay. If you go to, if you're flying, if you're taken a flight, and if you touch or if you abuse or fight with the pilot or with the air hostess, you are immediately arrested. If you are a public servant, you will be immediately taken into custody if you are obstructing his work. You cannot obstruct a bureaucrat. You cannot go and fight with the bureaucrat. You cannot fight with the police people.
Even any government service.
Yes,
any government servant.
Any public servant.
Any public servant.
Any public
If
servant.
something happen कि राज काज के अंदर रुकावट और उसके साथ मारपीट, बहुत ऐसा अपराध क्रिएट कर देते हैं जिसके कारण कि वो तुरंत अरेस्ट होगा, उसकी बेल भी नहीं हो सकती।
उसकी बेल भी नहीं हो सकती। तो ये चीज़ हम लोग ये मांग रहे हैं कि डॉक्टर के ऊपर में भी ड्यूटी पे करो।
बिल्कुल।
जब डॉक्टर ड्यूटी पे है तो उसको ये प्रोटेक्शन मिलना चाहिए।
ये ऑलरेडी प्रोटेक्शन के अंदर है।
डॉक्टर का नहीं है, पब्लिक डॉक्टर का है, गवर्नमेंट डॉक्टर का है।
पब्लिक डॉक्टर का है, और इसके अंदर भी कितनी ही धाराएं आती हैं जिसके अंदर हो सकता है, लेकिन इसके लिए जब तक स्पेशल एक्ट नहीं होगा स्पेशल एक्ट जब तक नहीं होएगा, जब तक न तो जो इसको इम्प्लीमेंट करने वाले हैं और न पुलिस को और प्रशासन को, दोनों को अपने किस तरीके से बातें कर कर जो एक तरीके से रिसिपिएंट है, जो मरीज है, या उनके साथ जो हुल्लड़बाजी करते हैं, वो सब लोकल मिसक्रिएंट्स होते हैं। और लोकल मिसक्रिएंट्स अपना पावर बताने के लिए ये सारी की सारी करते हैं, और उसके कारण जो पुलिस और जो प्रशासन है वो उनके कारण कोई एक्शन नहीं ले पाते हैं। और जो सॉफ्ट टारगेट होता है वो डॉक्टर हो जाता है कि भाई ये बीमार आया था, उसका काम नहीं हुआ है। तो जब तक इसके लिए मंशा नहीं होगी और एक स्ट्रिंजेंट लॉ अपने सब जगह नहीं बनेगा, और अगर उसके लिए बनने के साथ ही हमको उसके बारे के अंदर अगर वो इम्प्लीमेंट नहीं करते हैं, तो हमको कोर्ट के अंदर उसके लिए प्रसंज्ञान लेना पड़ेगा, जब है जो हम इसको इम्प्लीमेंट करा सकते हैं।
Jithu bhai, suppose the ministry meeting is happening on it. They have accepted our demand. There will be the law secretary and health secretary, MCI, IMA will sit together. Most of the, when we talk about 17 states, there is a law. If you want to have a central law, what are the punishment we are looking for? I mean, I want a consensus between three of you. What punishment we should ask that if somebody, a doctor is violates a person in a medical establishment, should it be a non-bailable or a bailable offence? That's one. And to make non-bailable, you have to have an imprisonment of more than 3 years. So should we insist on a non-bailable offence?
I'm happy that because of the earnest efforts of the office bearers of the Indian Medical Association in last year, there is a strong bonding and cooperation between the Ministry of the Indian government and also with the IMA. And with these efforts, now there is a consensus that some mechanism must be there to resolve the issues pertaining to the medical profession. Now coming to the point on the assault of doctors, I think it should be non-bailable. Because we are trying to serve the people. The intention of any of the doctors in the world cannot be to kill the patient or to do something which is against the interest of the patient. We are doing for the humanity work, but because of our own constraints and because of our own limitations, we can do something only. So therefore, it is the need of the hour that to serve the humanity in the best possible way without fear, if the stringent law which is non-bailable against the people who are doing the assault on the doctors should be mandatory, and we must impress upon the government that it should be non-bailable with a punishment of 3 years, rigorous imprisonment.
आप जो कह रहे हैं नॉन बेलेबल, अभी भी जितने भी ऑफेंसेज हैं वो असार्ट करने के नॉन बेलेबल ही हैं, लेकिन अब नॉन बेलेबल को वो बेलेबल नॉन बेलेबल होते हैं, अरेस्ट किया और बेल थाने में दी और वापस छोड़ देते हैं।
नॉन बेलेबल मींस
मैं कह रहा हूँ कि आजकल जो कमिश्नरेट के अंदर और जहाँ कमिश्नरेट है वहाँ पर जुडिशियल कमिश्नरेट उसी टाइम शाम को बैठ जाता है और वो बेल कर देता है साथ के साथ। इसलिए अपन को उसके अंदर ये है कि ये पर्टिकुलर जुडिशियल ऑफिसर ये है वही बेल दे सकता है, किसी भी उसके अंदर उसकी बेल नहीं हो सकती है। इस प्रकार का जब तक उसके अंदर क्लॉज नहीं आएगा, क्योंकि आज भी बहुत जगह जो है ना वो नॉन बेलेबल है, उसको उसी टाइम अरेस्ट करते हैं और अरेस्ट करके थोड़ी देर बाद के अंदर या शाम तक जो है उसको छोड़ देते हैं। तो जब तक आप उसको नहीं करोगे, क्योंकि वो जो मिसक्रिएंट्स हैं वो मिसक्रिएंट्स ऐसा कर कर आप ये कह सकते हैं कि वो जिस प्रकार से ब्लैकमेलिंग होती है कि वो तो कर दिया और उसको गिरफ्तार भी हो गया, गिरफ्तार होकर वापस छूट गया और छूटने के बाद में वो वापस
it has to be a non-bailable
and made only by the judicial.
Why we are demanding for a central act is that there has to be changes in the police manual. With the state act, change in police manual cannot happen. Only the manual, there is a change in the manual, then only the police can immediately act and also charge a case which is not criminal case which is non-bailable. It has to be there. Many of the state acts, if you look at it, the clauses are very variable. in some states, not only it has to be a criminal act and non-bailable act, but then imprisonment has to be there and compensation for the property loss or the because of the assault, whatever loss to the individual is there, also has to be given. Some state does not mention that. So not only that, in certain states, although the act is there, the rules are not framed. To that extent, effective implementation of the act is difficult. So it is time that we have a central act.
On yet when we go,
Yeah.
we insist on non-billable.
Yeah. And central act, just like
non-billable
sort of harassment of
With a rigorous
women,
imprisonment of 3 years.
which is act is very, very strict. So similar act has to come. Harassment to women.
Like the second point we are discussing there is capping. Second point we are discussing there is capping. So we said we want capping. Consumer Ministry Joint Secretary will be there. And the reasons we have written so far is there is a capping in what I can charge. That means in PSU, in CGHS, everywhere there is a capping. I cannot charge more than this amount. For sterilization death, 2 lakh capping is there. Sterilization failure, 30,000 capping is there. For sterilization complications, 25,000 capping is there. For any flood or anything, 2 to 3 lakhs capping is there. There is a precedence. For air disaster, 1 crore capping is there. For railway accident, there is a capping. There is a fixed amount of money. You cannot be paid more than that. Now the Supreme Court says no. They say you will charge according to the income of a person. And they say 70 minus age at death or at disability multiplied by annual income plus 30% for his growth. The Supreme Court formula is a person can never grow. He can only grow 30% during his lifetime minus 1/3, and that will be the compensation decided. I'll give you a simple example from our own Prime Minister. If our Prime Minister would have got a problem when he was selling a tea, his compensation would have been different. Nobody can realize that even a tea seller can become the Prime Minister of India. So therefore this formula is wrong. So we are saying there has to be a capping. So if there is a capping, what formula are we suggesting? Starting from what will it? Suppose they agree for capping.
Yeah.
Then the next step.
We
you will
have
say,
clearly and categorically mentioned that there should be capping. Capping is not some new innovation by us, because all over the world there is copying.
Yes.
Yeah, whether it is in America, every state has its own rules with variations, but then capping is already there. Australia, England, everywhere there is capping. And particularly when natural disaster come or accidents come or crash come, the government is only paying hardly, irrespective of the income, they are paying 10 lakhs or even that much they are not paying. Then doing a course of treatment where we don't mean any harm to the patient. Suppose something goes wrong inadvertently, why such a big compensation should be on doctors alone? Particularly in our country where doctors are not available enough. In America, England and other places, they practice only for a few years and voluntarily they retire. But then those countries can sort of afford it because number of doctors there are much more. India, where doctors are very few, if we start retiring just because of fear of compensation, then our health delivery will be in a very catastrophic situation. More than that, even this multiplier method that you have been mentioning, here again, that's not properly applied. Because somebody who comes as a patient to you, definitely is going to have some handicap. It is the beginning of his illness that he comes. Whether you treat him or not treat him, he is going to be handicapped. With treatment he may improve, but he may not become normal in his activities. So even application of this is wrong. Over the years, because of ill health, his sort of earning capacity is going to become less. So it has to be the reverse order. Rather than thinking that every year his productivity is going to increase, it is going to decrease dramatically. And if that way the multiplier system is applied, again we can justify that the amount to be paid will be less.
Suppose we say.
So, but then all these are arbitrarily done.
Suppose we permit capping.
Yeah.
What do we want?
नहीं, we just
Is the number we are going to suggest?
नहीं, capping means what he has paid. उसका कितना भी अलग अलग जगह अलग अलग प्रोसीजर्स के अलग अलग जो है ना चार्जेस दिए जाते हैं, अलग अलग से चार्जेस दिए जाते हैं। और जब सुप्रीम कोर्ट भी ये मानता है कि उसकी कैपेसिटी क्या थी, उसकी अर्निंग क्या थी और उसके अनुसार लिया जाए, तो उसने जो कुछ पेड किया है उसके कुछ गुना उसको वापस दिए जाए।
No, even that's not possible, because if a very rich patient comes to you, you are not going to charge more. But if you are going to give compensation for a very rich man, then it depends on his income. So that we cannot just because a very rich man, the compensation is more,
going to suggest
we cannot charge more.
That not more than 1 crore.
नहीं,
I'm asking simple question. On that day when we go
I
away,
think you are absolutely right.
are we going with a number that we don't want any compensation more than 1 crore or more than 50 lakhs, whatever? Is there
Not
any number?
1 crore or 50 lakhs. It has to be around 10 lakhs or something.
Whatever it is.
what I am suggesting कि what he pays is 10 times, 20 times, 5 times. We can make this formula only कि what he paid.
So whatever his bill is, 10 times or 15 times.
But that's all. That's all.
Suppose
So
his bill is 1 lakh, then maximum 10 lakhs.
Yes. If he paid only this 15,000, then he will get 1,50,000. This is the क्योंकि
Even for that, there has to be a higher limit. That is exactly what we are saying, capping has to be there. The highest limit
okay
cannot be say more than 10 lakhs.
नहीं, both we can say
Yeah.
कि 10 times or 10 lakhs, whichever is more, whichever is more.
If there is a death due to some accident, how much amount is given to that person?
They are calculating with the multiplier method. That is the irony.
Traffic.
In a road traffic
According
accident,
to road traffic accident.
cannot be compared here because that cannot be compared here because there is no money spent by the person who is getting an accident.
Not only that, see,
So they
road
will cannot
traffic
compare the-
accident,
Road traffic
accident
But
happens.
even
Accident happens in people who are between say 19 years and 40 years. In their prime of life, they don't have any disease, most of them. And that's why even if multiplier system is applied, it's okay. But here we have somebody who is handicapped physically, even mentally, and his earning capacity is definitely going to be less. Then how can you apply the multiplier system?
So we are going to we have still time till it. So we need a capping. There has to be upper limit.
Yes.
Let there be consensus, and there also can be a formula of it has to be linked to the money paid, not with that you have money earned. How much money you are earning? How
Yes,
much
yes,
money you are
yes,
earning?
yes.
Otherwise, tomorrow what will happen is a person who is earning in crores, he may go to a free OPD, and his compensation can be very high. This is the second point we are discussing. The third point we are discussing on that day is PCP and DP, and the national president and we were there in the last meeting. That is to address on what lines ministries are already thinking of in terms of PCP and DP.
In BCP Act, we can more or less say that we have been very successful because of our campaign and because of our press releases and press conferences and getting the stakeholders together. We could almost convince the government that there is a need for amendment. And I must say that the final stage of amendment has been reached. In the last meeting we had with the government, the final stage of amendment has come in, and we have very strongly said that although IMA is with the government, as far as female feticide is concerned, any step to reduce female feticide, IMA is with the government. In terms of punishment for doctors who do female feticide or abet or aid female feticide, that is very clear. But then the same act is applied for non-compliance or for trivial things like sort of some mistake in the filling of the form, not displaying your registration certificate, not having a copy of your act on your table, not wearing a badge or coat or things like that. So these are all non-compliance or trivial mistakes for which a criminal clause should not be attracted. We feel that government is also convinced with our argument, and for these sort of non-compliance, we feel that it has to be just fine. If it is repeated, of course, the amount of the fine can increase, and if that is agreeable, that's not the only anomaly in the act, but this is a major anomaly
Yes.
which has to be addressed. There are many other anomalies which definitely has to be considered by the government. But if this major anomaly is corrected, to some extent, it is a relief for the medical profession, and it will be in the best interest of public health.
What do I say?
We are the Indian Medical Association is against the female feticide, and we are committed for the daughters of this country. But at the same time, a trivial typographical mistake should not be the cause for a imprisonment. Even a typographical mistake can make somebody a minister, and the same clause is not applied in that case. A small typographical mistake in Gujarat, I think the 3 months imprisonment and 10,000 rupees fine was, imposed on a doctor from Sipur.
Similar cases.
I think that is very dangerous.
Throughout the country.
That is very dangerous.
Yesterday, one doctor came to me, and she is from North India, and her husband was managing a child. He was a newborn or something, and the child developed septicemia. Okay. The complaint has been filed on 269 for jail that you are responsible for producing a circumstance that my child developed septicemia. So if this is going to be the scenario, say when 304A came, somebody started 304A, we fought, Jacob Matthew case came, and the Supreme Court came out with the guidelines. Now people have started, they are not talking about medical counsel, they are not talking about consumer. Now people are sitting with the lawyers and finding out under what IPC section they can file a case against the doctor.
Yes.
And then 269 means that that means every case of hospital acquired infection is a common phenomenon. 10% is accepted, 5% is accepted internationally. If every case of septicemia, people are going to go back to the police and say because of that, even if police doesn't file a case, at least there will be opportunity for a police to harass you. And that's what is happening. Why should IMA allow criminal cases against doctors and their treatment? When the treatment is there, it has to be either a misconduct, professional misconduct, or a negligence, which is compulsory, for which you are.
It is already immunity to the doctors in the this criminal procedure code. When the doctors is doing their professional duty with the good cause, until unless he cannot be prosecuted. It is.
Under IPC 89 and 90 जो आप बात कर रहे हैं, that is in good faith. That if you have done anything in good faith, will not be a crime.
Yeah.
Okay, but who decides that good faith? It's the magistrate. Police will come and arrest you. See, that is your defense. That I have done it in a good faith, therefore this is not a criminal act. But they are going to file you a cases again 269, 27. I mean, this is I just said 420.
Because of
extortion.
I think
because of the ignorance,
powers
because of
must
the
be with the
ignorance.
judiciary rather than with the police to arrest any doctor.
Yes, this should be. There should be during the treatment. If anything happen, police cannot arrest any doctor.
That is the Supreme Court guidelines under Jacob Matthew in a criminal offence 304A. Under 304A. But now people are finding out other clauses from the IPC to harass the doctors. So I'm only trying to say is, IPC courts, we should have a campaign. I'm talking about apart from these 5, this is another issue which we should consider is, why should doctors be punished or even imprisoned or even cases be accepted under Indian Penal Code? That's what my thing is. Next is, the time is less, Clinical Establishment Act. In a Clinical Establishment Act, we want single clinic to be out, smaller establishments to be out, and we want accreditation by NABH and not by CEA.
Yeah, Clinical Establishment Act, although the intention of the act is good, the way the rules are framed definitely goes against the interest of the public health. Because as we see, 40% of our population depend on small, medium level hospitals. And this is the segment of hospital which will be adversely affected by the Clinical Establishment Act in terms of the additional financial burden that we impose to maintain certain standards which the Act proposes to have. And already these small medium hospitals are sort of financially viabilities in question and are being closed down. And this will further enhance the closing out of these hospitals. IMA is not against minimum standards. IMA want the standards of healthcare to improve, but then it is not through this act it can be done. So IMA's suggestion is that single-man hospitals has to be excluded from the purview of Clinical Establishment Act, because as per the act, you should have this much of space for your practice. You should have rest space, air-conditioned room, a nurse, pharmacist, and other stuff. But then a single-man clinic, a doctor is a nurse, he is a pharmacist, he is an attender, everything in one. And just because he is doing it like that, he is able to subsidize the healthcare to the very poor and needy, particularly in inaccessible areas. So putting all this burden on this single man clinic definitely is going to make healthcare much more costlier. And even those who are taking the risk to have single man clinic may think twice before they decide to continue it or not. So this segment has to come out of this act. Second is, of course, the small and medium level hospitals, where for maintaining of the standards, IMA has taken initiative to see that entry level accreditation by NABH, where the emphasis is on is more on the treatment protocol and things like that, rather than on infrastructure and other facilities. If a small and medium level hospital has entry level accreditation NABH, all that the hospital has to do is to register and not go through other paraphernalia. So if these two things are done, partly IMA is comfortable with this act.
No, one more thing. This police should not be any role in the clinical establishment act.
Yes,
This is the very, very important, and the appropriate authority must be a CMHO or of that district, or at the state level, the director medical and health or his nominee, not below the rank of the deputy director.
Even
the appropriate authority.
Then also it will make it job very difficult, because looking to the rampant corruption in the system, I think will be harassed like anything by any individual. Therefore, our emphasis must be that the modus operandi which is implemented in the Western world cannot be executed in our country because of the poor socio-economical condition. The single clinic must be out of this purview of Clinical Establishment Act, and at the same time the Clinical Establishment Act should not be against the public, because otherwise it will make a treatment more costly. If you try to pursue the mediums, even the hospitals to have a minimum standards, that will certainly raise the financial burden on the patient. So I think we have to be rationalized, government should be rationalized, that the poorest of the poor of this country should get a very good treatment at a very distant level. If there is a fear of Clinical Establishment Act, no doctor will take any serious patient to his hospital, and that will cost more to the poor patient.
Not only that, the act itself has not taken the ground reality into consideration by framing the act itself and the rules. Because we are already short of nurses, we are in short of paramedics, we are in short of basic doctors, we are much more in short of specialists. And when such a situation,
some is qualified, some is experienced. But both the qualified and experienced, it will be very difficult to get the persons of qualified as well as the experienced. many paramedicals, they are experienced, but they are not qualified, but they are doing work equally as more than this qualified. So there should be a rationalized of this how these paramedicals qualifications etc. We cannot get the resource.
Yeah, the first thing the government should do is see that the number of doctors, paramedics and others are available in the proportion that it should be. Then only think of an act to standardize. So you say that you should have a qualified nurse, depending upon the number of beds. If the India is not producing enough of nurses, then do you mean to say that you have to close down all these establishments? Just because you don't have enough qualified nurse, let government provide enough qualified nurse. Let government provide enough health workers, pharmacists, and other categories, and have enough of specialists. Then think of standardization. So the IMATV is definitely a process of self-accreditation, the basic accreditation, that is entry-level accreditation. And without that amendment, this act is going to do a lot of harm to public health rather than good.
That's all for today. Let's thank Dr. Pillai, Dr. S.S. Agarwal, as well as Dr. Jitubhai Patel to be here with us. And we'll be back tomorrow, same time. And tomorrow we'll have Dr. Prakash Trivedi, the FOXY president, who is visiting Delhi. We'll be interacting with him on many other issues. Till that, say goodbye. Thank you.
Hello. हाँ